Hi, I'm John Lorraine. I'm the Marsh Assistant Professor of Gynecologic Oncology at Northwestern University Feinberg School of Medicine and the Robert H. Lurie Comprehensive Cancer Center. I also am the director of the Brewer Trophoblastic Disease Center, which is a specialty center here at Northwestern that was created in 1962 for the consultation and management of these fairly rare diseases, which are the gestational trophoblastic diseases, and that's what I'm going to talk to you about today. Okay, I have no disclosures. John Brewer started the Gestational Trophoblastic Disease Center here at Northwestern in 1962, and was the first place outside the National Cancer Institute to give chemotherapy for the management of these diseases. Most of what I'm going to tell you today, I learned from Dr. Brewer when I arrived here at Northwestern in 1979. Dr. Brewer was 75 at that time. I used to meet with him every Friday for an hour and a half to talk about these patients and to learn from him. Today, at the end of this talk, I'd like you to be able to explain sort of the pathophysiology of the gestational trophoblastic diseases, to be able to understand and describe the genetics of the formation of these specialized tumors called hydatidiform moles, to diagnose and develop a plan of management for a molar pregnancy or a hydatidiform mole, define what gestational trophoblastic neoplasia is, choose the appropriate treatment options for gestational trophoblastic disease based on stage and risk assessment, and be able to summarize the most important reasons for success or failure in the treatment of gestational trophoblastic disease. There are essentially four gestational trophoblastic diseases. There's hydatidiform mole or molar pregnancy, invasive mole, choriocarcinoma, and placental site trophoblastic tumor, or its related epithelioid trophoblastic tumor. And we'll go through each of these so you can understand what they are. A hydatidiform mole or molar pregnancy occurs when there's abnormal fertilization, or when the time of reproduction, when the sperm and the egg meet. Ordinarily, one sperm fertilizes a normal egg, which results in a normal pregnancy. When a sperm fertilizes an egg in which the genetic material is either absent or not expressed or disrupted in some way, so that the maternal chromosome complement is not present, the sperm replicates itself. So you end up with a 46XX product of conception, but there's no fetus because there's no maternal contribution. And so the placental tissue starts growing abnormally into this big placental gamush with large vesicles without any fetus. Occasionally, two sperm fertilize an empty egg, so you can get a molar pregnancy from that. There's also a condition that's called a partial molar pregnancy, where you get two sperm fertilizing a normal egg, and so you end up with too many chromosomes and an abnormal fetus, and a portion of the placenta then becomes the same, changes where the villi or the placenta looks very hydropic or distended with cystic fluid masses. There's a very rare condition where a woman has a somatic mutation where she's unable to have a normal pregnancy. And every time she gets pregnant, she ends up with a molar pregnancy, not because of an abnormal event at the time of fertilization, but because there's a chromosomal abnormality that doesn't allow for normal fetal development. So we talked a little bit about a molar pregnancy. A complete molar pregnancy occurs when there's this fertilization of a normal sperm with an empty or disrupted egg. Grossly, the placenta is filled with these little villi, which are ordinarily present. They get fluid-filled, they form big cysts, and there's no fetus or embryo that's present. Microscopically, there's the trophoblast, the placental tissue called the trophoblast. is hyperplastic or enlarging and spreading throughout and around these water-filled cystic villi. And there are no blood vessels that go within these villi that usually occur. This is what a molar pregnancy, or a complete molar pregnancy, or a hydatidiform mole looks like. This patient had her uterus removed in order to treat this, which isn't the usual condition. Most of these can be treated by suction evacuation and curettage. But this preserved these, you can see these villi here very clearly, these big cysts here with no fetus or embryo. And microscopically, you can see these big dilated villi with no blood vessels, and this tissue here around the outside is the trophoblast that's proliferating. Microscopically, you can see two types of trophoblasts usually. There's the cytotrophoblast, which are these mononuclear cells with vacuolated cytoplasm that are involved in growth and replication of the trophoblast. And then there's the syncytium, which are these multinucleated cells which are derived from the cytotrophoblast by a process of membrane dissolution and coalescence. And these are involved in membrane transport and hormone production. And this is where the pregnancy hormone, human chorionic gonadotropin, or HCG, is made. Remember I mentioned that there's such a thing called a partial mole, which is involved with when two sperm fertilize a normal egg, and you end up with some of these same conditions, but most of the time this diagnosis is usually made by the pathologist after a D&C for a missed abortion or spontaneous abortion. These cystic changes in the placenta and the proliferation of the trophoblast is less exuberant, and if you do genetic testing on these, you can see that these are triploid, or there are 69 chromosomes. This is what this might look like. There's these cystic spaces here in the placental tissue, and there's an abnormal fetus over here. Once again, this is a partial hydatidiform mole, microscopic picture, and you can see that the hydropic degeneration of these villi isn't as great as in a complete mole, and the trophoblastic proliferation isn't as exuberant. Invasive mole occurs when, after you evacuate a hydatidiform mole or molar pregnancy from the uterus, there's still tissue growing into the wall of the uterus, and this can persist after evacuation of the molar pregnancy from the uterus. And this usually presents by a persistently enlarged uterus, continued bleeding, and persistent elevation of the pregnancy hormone, human chorionic gonadotropin. These can invade into the blood vessels within the uterus and can actually be deported to the lungs, where they may show up as metastasis, but the invasive mole cannot metastasize to other parts of the body because it's not really cancer. This is what this will look like in a patient who had a hysterectomy for treatment of this, which isn't always necessary. Most of the time this can be treated with chemotherapy. But you can see here this tumor within the wall of the uterus that's been cut in half, and these little, you can even see these little vesicles grossly here. And microscocopically, you can see this hydropic villus and its investing trophoblast growing into the wall of the uterus. And you can even occasionally see these hydropic villi, which is from the molar pregnancy, in the walls of a blood vessel. Now, choriocarcinoma is real cancer of the trophoblast. That means the trophoblast is not only hyperplastic, but there's actually anaplasia of the trophoblast. It's really ugly looking. There are no longer any villi present, which are usually present in pregnancy. There's a lot of hemorrhage or bleeding and necrosis or dying of the tissues because this is rapidly growing. And you get invasion of adjacent structures as well as metastasis to distant sites. This is what a choriocarcinoma looks like in the uterus. Here's the uterus, and it's been cut in half again, and there's this big hemorrhagic, nasty-looking tumor within the uterus. And microscopically, you can still see the alternating patterns of the cytotrophoblast and the syncytial trophoblast, but a lot uglier, more anaplastic tissue, and no villi present. A placental-site trophoblastic tumor is a very rare tumor. This is a tumor of what we call intermediate trophoblast, somewhere between cyto and syncytial trophoblast. There's less hemorrhage and necrosis than there is with choriocarcinoma. They have a propensity for lymphatic spread rather than hematogenous spread. The HCG levels are relatively low because HCG is made in the syncytial trophoblast, and there isn't much of that around in these tumors. These tend to be more resistant to chemotherapy than the usual types of invasive mole or choriocarcinoma we treat. And the usual treatment for these is a hysterectomy with or without some form of chemotherapy. Patients who have these tumors that occur a longer time from the prior pregnancy or have a deeper invasion into the wall of uterus or more active mitoses or dividing cells are at increased risk, and some of these patients, even though they have no evidence of metastatic disease, may need chemotherapy to be cured. This is what this looks like. Here again, you can see the uterus is cut in half, and here's this big tumor here in the upper portion of the uterus, and microscopically you can see these intermediate trophoblastic tumor cells that are streaming between the normal myometrial cells, which are the muscle of the muscle wall of the uterus. Now, gestational trophoblastic disease is relatively rare. Hydatidiform moles or molar pregnancies occur about once in every 1,000 to 1,500 pregnancies in the United States. In certain parts of the world, such as the Far East and Mexico, they occur more frequently, probably related to nutritional deficiencies in a diet, especially with related to carotene. Molar pregnancies are more common at the extremes of reproductive age, and that is women who are younger or older have a higher risk of molar pregnancy per pregnancy event. About 20% of patients who have a molar pregnancy will then go on and need chemotherapy for what we call gestational trophoblastic neoplasia, which could either be invasive mole or choriocarcinoma. Choriocarcinoma occurs once in every 40,000 pregnancies. About half of those are related to prior hydatidiform moles or molar pregnancies. The other half are associated with regular pregnancies, term gestations, preterm gestations, miscarriages, or even ectopic pregnancies. Clinical signs of molar pregnancy: most patients have bleeding that occurs in the late first trimester, early second trimester. The uterus may be larger than expected for gestational dates. Preeclampsia or signs of toxemia pregnancy that occurs early in pregnancy may be a sign of hydatidiform mole. These patients very often have excess nausea and vomiting or hyperemesis gravidarum. Now that we do ultrasound early in pregnancy, most patients are found to have molar pregnancies early in gestation before they develop any significant signs of these other medical complications. And so most patients do very well because they're having the diagnosis made early in the first trimester of their or early second trimester of their pregnancy. The way we diagnose these now is by ultrasound. If someone has something that thinks is wrong with the pregnancy, you can do an ultrasound, and what you'll see is this big placental gamush with a bunch of holes in it, which are these echoes off of these large dilated villi in the pregnancy, and there's no fetus or embryo that's formed. So this is pretty pathognomonic of a molar pregnancy, and this requires that the molar pregnancy be evacuated from the patient. And the way we do that is usually by suction evacuation and curettage, or D&C. Occasionally, we do this by hysterectomy, especially for patients who desire a a sterilization procedure, or women who are older who may be at increased risk for the development of post-molar gestational trophoblastic neoplasia that we talked about. So we want to make certain that the patient's hemodynamically stable. We do type in screen on these patients because if they're Rh negative, we need to give them RhoGAM. And if they're not any in particular problem, we simply evacuate the uterus in the operating room under ultrasound guidance. We do not recommend medical induction of labor or hysterotomy, or sort of removing the molar pregnancy through like a cesarean section, because that increases the maternal morbidity and also it increases the risk for developing post-molar gestational trophoblastic neoplasia that will require chemotherapy. After we evacuate the molar pregnancy from the woman, we follow the patient with serial serum quantitative HCG levels, or pregnancy hormone levels, every 1 to 2 weeks until they're negative for 3 consecutive terminations, and then every 3 months for 6 months. We ask the patient to come back for a physical examination about 1 month after the D&C or surgery to make certain that everything seems to be going okay, and we ask the patient to use contraception during the follow-up period. Oral contraceptives are preferred because they're excellent contraception, and they will also suppress pituitary hormones that may interfere with the measurement of HCG at low levels. If the HCG should plateau for 4 values over 3 weeks, or should rise for 2 values over 3 weeks, or is persistently elevated for 6 months after D&C, then we have to evaluate the patient for chemotherapy. Anytime we make a histologic diagnosis of choriocarcinoma or detect metastases, we also treat the patient with chemotherapy. Back before we knew how to do HCG levels very accurately, we had a lot of patients referred to our center for follow-up of HCGs after molar pregnancy evacuation. And when I went back and looked at these patients in the early 1980s, I found that 80% of these patients essentially returned to normal spontaneously when we followed their HCGs. 19% of the patients we felt required chemotherapy. They received chemotherapy, and all of those patients were cured. So clearly, if you follow the HCGs appropriately and make appropriate decisions regarding treatment and give the appropriate treatment, everyone who has a hydatidiform mole should be cured of their disease. There are certain patients who are at higher risk for the development of post-molar gestational trophoblastic neoplasia, and those are patients who have a very large uterus or greater than 20 weeks gestational size, theca-lutein cysts, which are these large cysts that develop on the ovaries due to the very high HCG levels that are encountered with molar pregnancy. Patients who are older have an increased risk for developing post-molar gestational trophoblastic disease. Those patients who have medical complications of their molar pregnancy, such as toxemia pregnancy or hyperthyroidism or trophoblastic embolization, are at higher risk. And it appears that those women who have had more than one or who have had a prior hydatidiform mole are also at greater risk for developing post-molar gestational trophoblastic disease in a subsequent molar pregnancy. Well, molar pregnancy is an index pregnancy, and so it tips us off to what's going on, and there's no woman who has a molar pregnancy who should get in trouble and die from this disease. We can identify the disease, the molar pregnancy, we can evacuate it from the patient, follow the HCG levels, and then make decisions whether or not the patient needs chemotherapy, and everybody we treat with chemotherapy should be cured. The problem is that that doesn't happen all the time for a variety of reasons, and also about half the patients who have choriocarcinoma have choriocarcinoma associated with a non-molar pregnancy. So there's not that index pregnancy that tips us off to something's going wrong. So very often patients who have choriocarcinoma following like a term gestation will come in with widely metastatic disease because these tumors spread rapidly throughout the bloodstream and can go to the lungs, brain, kidney, liver, a variety of other places. So when we have a patient that we think has a gestational trophoblastic neoplasia, whether that's following a molar pregnancy or some other type of pregnancy, we need to take a thorough history and physical examination. We do a survey for metastatic disease, which includes a chest x-ray, some CT scans, brain MRI if we find any other evidence of disease, and measure their HCG level. These are some scans of patients who have had gestational trophoblastic neoplasia, and this is a CT scan looking up like from the bottom up towards from the legs up towards the patient's head, and it's a cross section. And it's a cross section through the uterus here. And this is the pelvis, pelvic bones, and through the uterus here. And you can see there is an invasive mole in the wall of this uterus. This is a patient who has a chest x-ray with multiple sort of what we call cannonball metastases, which are these peripherally located metastatic lesions in the lungs, who's had choriocarcinoma. This is a CT scan through the lungs, and you can see here also small tumors in the periphery of the lung. This is a CT scan, again through the pelvis of a woman who had normal delivery and then had bleeding several weeks postpartum. And this is a big necrotic choriocarcinoma in the cavity of the uterus. This is a patient who has This is a CT scan through the liver and spleen in the upper abdomen, and you can see here tumors in the liver and spleen from a metastatic choriocarcinoma. This is a scan through the brain of a patient who has a tumor in the frontal lobe of her brain. This is a angiogram or arteriogram of the pelvis. These are the common iliac arteries here, and on this side, this is the external iliac artery. It goes down to the leg. This is the internal iliac artery, and then comes up into the pelvis, and the uterine artery comes off of that in this sort of squiggly little line here. On this side, you can see there's this big tumor blush, and this is from choriocarcinoma invading out into the tissue next to the uterus. Now, all of those films, all those patients whose films I showed you are all alive and well today because of modern treatment for a metastatic gestational choriocarcinoma or other gestational trophoblastic neoplasms. That wasn't always the case. Back before the pre-chemotherapy era, about 15% of patients who had invasive mole, that's just molar tissue growing in the wall of uterus, would die from their disease, usually related to hemorrhage or infection. Patients who had a choriocarcinoma that was what was thought to be confined to the uterus and underwent hysterectomy, only 40% of those patients were cured. And virtually every patient who had metastatic disease died of their disease. Well, back in the late 1950s and early 1960s, investigators at the National Cancer Institute began looking at the growth and replication of trophoblastic tissue. And a man named Roy Hertz was interested in nutritional requirements for the growth of trophoblasts, and he noticed that folinic acid seemed to be important, a nutritional component for growth and replication of trophoblast. Another man named M.C. Lee had made some clinical observations that when he treated patients with a methotrexate drug, which is a folinic acid antagonist, that in fact their HCG level went down, and the two of them then got together and started treating patients who had metastatic gestational choriocarcinoma at the National Cancer Institute in 1956 with a drug called methotrexate, a folic acid antagonist. And of the patients they initially treated, they cured almost half the patients, as opposed to almost none before that. Six patients died from drug toxicity because they hadn't really figured out how to give the drug at that time. They figured that out. Another drug came along in the next 5 years called actinomycin D. They treated patients sequentially with these drugs, and they were able to cure almost 3/4 of the patients they treated over the next 5 years who had metastatic choriocarcinoma. And there were no treatment-related deaths during that time. They also figured out that, hey, if you can cure metastatic cancer with these drugs, maybe you can cure non-metastatic disease. That's disease still confined to the uterus with chemotherapy without having to do a hysterectomy and preserve a woman's reproductive function. And in fact, that's what they found. They were able to cure all but one patient who had no evidence of metastatic disease at the time of treatment, and all but one of those was able to maintain her reproductive function. They came up with a classification scheme at that time that there were certain patients who were at higher risk for the failure of single-agent methotrexate or actinomycin D chemotherapy. And those were patients who had very high HCG levels, those who had a long duration of disease, which they defined as greater than 4 months, patients that have disease spread beyond the pelvis or lungs, like into the brain or liver, those patients who had failed prior chemotherapy before being sent to the NCI, and those patients who had disease associated with a term gestation, had a worse prognosis. So this came about, there was the low-risk patients and the high-risk patients. Those patients who had low-risk disease could be treated with single-agent chemotherapy with a high expectation of cure, whereas those patients who had high-risk disease needed more aggressive therapy. There's a gentleman in England named Bagshaw who then came up with a scoring system based on weighted scoring of a variety of factors, most of which the group at the NCI had identified, and patients that had a score of 7 or greater were at higher risk for failure of single-agent chemotherapy. The International Federation for Gynecology and Obstetrics came up with a staging system, an anatomic staging system, looking at stage 1 being no evidence of metastatic disease, stage 2 pelvic disease, stage 3 spread to the lungs and or pelvis, and stage 4 disease spread beyond the lungs and pelvis. It then used this combination of an anatomic staging system and a scoring system to try to figure out which patients were the highest risk for treatment failure and needed more aggressive therapy. When we looked at this data in retrospect at the Brewer Center, we found that those patients who had stage 3 disease, that meant lung metastases, but had a score of less than 7, those patients did uniformly well, except for one patient who was treated very early in the series who died of hemorrhage. Whereas those patients who had a score of 7 or greater, only 2/3 of those patients were cured. We also looked at whether or not the patients had metastatic disease and a score, and you can see that those patients who were at the higher risk were those patients who had a metastatic disease with a score of greater than 7. We found on multivariate analysis, looking at a variety of factors, that the number of metastases, the site of metastatic disease beyond the lung and pelvis, and whether a patient or not had failed prior therapy before being sent to the Brewer Center, those patients were at the greatest risk for subsequent treatment failure. So we sort of came up with this system where patients who are low risk can be treated with single-agent chemotherapy initially, and those are patients who have non-metastatic disease, or even if they have metastatic disease, but they have a low FIGO or WHO score, can still be treated with single-agent chemotherapy with a high expectation for cure. So we anticipate that all those patients with low-risk disease should be cured. Various combinations of methotrexate and actinomycin D have been used. There's still controversy as to which is the best related to cost, ease of administration, toxicity, and therapeutic effect of different treatment options. This is sort of a summary of the results of using these various combinations, and you can see that the best treatment seems to be multi-day methotrexate with or without folinic acid and multi-day actinomycin D. So the patients who seem to have the most resistance to single-agent chemotherapy, even this low-risk group of patients, are those who are older, have higher HCG levels, have a non-molar antecedent pregnancy. In other words, the disease occurs in like a term gestation or a miscarriage, have a real diagnosis of choriocarcinoma as opposed to possible invasive mole, have metastatic disease, and have a higher FIGO score, even if it's less than 7, if they have a score of 4 or 5, compared to those that have a 0, 1, or 2. They have a higher risk of treatment failure. When we looked at this years ago, we found that patients who had non-metastatic disease treated with methotrexate, the overall complete response rate was 89%, but all the patients ended up being cured with additional chemotherapy and/or surgery. And again, when we looked at the low-risk metastatic disease patients, again, the complete response to the initial treatment was about 66%, but all of those patients were eventually cured with additional multi-agent chemotherapy or surgery. The largest trophoblastic disease center in the world is in the UK, and they have 2 centers that treat patients there, as all patients who have trophoblastic disease in the United Kingdom are registered and treated at one of 2 centers. And the center at Charing Cross, treated with methotrexate folinic acid, had, again, a complete response rate of about 67%, but eventually all patients were cured, but some required multi-agent chemotherapy or surgery for that result. Again, the group in Sheffield, England, which is the other center, again had a 72% complete response rate to methotrexate with folinic acid rescue and an overall survival of almost 100%. The only randomized trial in treatment of low-risk gestational trophoblastic neoplasia was done by the Gynecologic Oncology Group a few years ago, where they looked at weekly IM methotrexate versus intravenous actinomycin D once every other week. And the response rate to the actinomycin D was much higher than the weekly intramuscular methotrexate, which sort of made this go away as a treatment. So we no longer recommend weekly intramuscular methotrexate for the treatment of gestational trophoblastic neoplasia. But the patients who got actinomycin D had a little bit more toxicity, and only one patient who actually had choriocarcinoma was cured by either one of these treatments. Therefore, we feel that a multi-day methotrexate regimen is the appropriate treatment, and when we looked at our data that we compiled at the Brewer Center between 1979 and 2009, we found we had 378 patients who were treated for low-risk disease. Most of those received single-agent chemotherapy with methotrexate for 5 days, and we found that the overall primary remission rate to single-agent chemotherapy in this group was 81%, and only 6% of patients required multi-agent chemotherapy or surgery to be cured, and all of those patients were cured. Patients who had metastatic disease or a higher score or a clinical pathologic diagnosis of choriocarcinoma had more resistance to single-agent chemotherapy, but eventually all ended up being cured. So we think that methotrexate, given for 5 days every other week, is an intravenous push medication, is the ideal treatment as first-line chemotherapy for low-risk gestational trophoblastic neoplasia, results in an overall complete response rate over 80%. Most patients who are resistant to the initial chemotherapy will be placed into remission by the addition of the other single agent, which is actinomycin D. Patients who have metastatic disease, a clinical pathologic diagnosis of choriocarcinoma, or resistance to the initial chemotherapy agent are at greater risk. And those patients, only 6% of patients require multi-agent chemotherapy, so there's low toxicity, and everyone was cured. Now, for patients who have high-risk gestational trophoblastic neoplasia, they require more aggressive therapy. And those are patients who have metastatic disease and or a score of greater than 7. Initially, at the Brewer Center in 1968, Dr. Brewer found out that patients who were treated with multi-agent chemotherapy using a combination of methotrexate, actinomycin D, and cyclophosphamide did better than those who received single-agent chemotherapy followed by combination chemotherapy. Also, Chuck Hammond at Duke Followed that up in 1973 again, looking at 17 what he called poor prognosis patients, and only 1 of 7 survived with initial single-agent chemotherapy versus 7 of 10 who were initially treated with this combination chemotherapy called MAC. So for treatment of high-risk disease, we now use multi-agent chemotherapy, and we've gone through a variety of these chemotherapy regimens. First, this methotrexate, actinomycin D, and cyclophosphamide, and then this coffee drink, I'm only teasing, Cytoxan, hydroxyurea, actinomycin D, methotrexate, some vincristine, or trade name Oncovin, followed by some more cyclophosphamide, and then polishing the patient off with some doxorubicin or adriamycin. This didn't work quite as well as the MAC, but it was very toxic. Along came a drug in the early 1980s called etoposide, and when put together with methotrexate and actinomycin D along with cyclophosphamide and vincristine, now forms the basis of what we call the recommended treatment for high-risk disease, this EMICO protocol. Patients who fail that then go on to treatment with some sort of platinum etoposide combination with bleomycin, ifosfamide, or paclitaxel, trade name Taxol. Patients who have brain metastases very often need brain irradiation. Patients who have resistant disease, we often excise disease, especially from the uterus or lungs, to treat them. This is the original data on the EMICO protocol. It showed that patients, about 80% of patients had a complete response to treatment, and the survival was 82% in high-risk disease when originally treated with this EMICO protocol, which was somewhere around 10% better than MAC. And a lot of people then reported on this, including us here. Pedro Escobar was a resident of ours at a time, and we reported on patients, our first 25 patients treated with EMICO with 92% overall survival. These are patients that have very high-risk disease with widely metastatic cancer. We then looked at a group of patients who were extremely high risk and treated with this EMICO protocol, and the complete response to therapy actually was only around 54%, but the survival was still 92%. There is no other disease where the complete response rate to initial chemotherapy is less than the survival. So this means that it's really important that the treatment after the initial primary treatment be optimized to result in this increased survival. Those patients who had high HCG levels, a longer duration of disease, metastases to sites other than the lungs and pelvis, or very high scores were those that had the less chance of responding to initial chemotherapy. There's a report out of England from the Charing Cross Hospital that there are certain patients who may benefit from induction chemotherapy with etoposide and platinum before going to the EMICO protocol, and it may decrease hemorrhagic deaths in the first few weeks of treatment. And those are patients that have very widely metastatic disease. And so there may be some evidence that inducing, starting out with some low dose etoposide and platinum for the first week or two, and then going to EMICO may be useful. So EMICO, or some variation of it, should be the treatment of choice for patients who have high-risk gestational trophoblastic neoplasia. But about 30 to 40% of patients will fail that first-line therapy or relapse from remission and will need additional treatment. But most of these patients will have high-risk features such as a clinical pathologic diagnosis of choriocarcinoma, a large tumor burden reflected by a high HCG level, multiple metastases to sites other than the lungs and pelvis, and very high FIGO scores. But salvage chemotherapy with platinum etoposide containing drug combinations with bleomycin, ifosfamide, or paclitaxel, often combined with surgical resection of sites of persistent tumor, usually in the lungs or uterus, will result in cures approaching 90%. After successful treatment for gestational trophoblastic neoplasia. It's important that patients have appropriate HCG follow-up. We do weekly follow-ups for the first month after completing chemotherapy, and then monthly for the next year. We ask them not to become pregnant for 1 year following the successful completion of chemotherapy, and using contraception during that time, preferably with oral contraceptive pills. If subsequent pregnancies, we ask that they obtain an ultrasound to document a normal pregnancy, that they have the placentas or products of conception, abortus material examined to make certain there's not a recurrence or a new type of gestational trophoblastic disease in the subsequent pregnancy. And we ask them, most importantly, to obtain serum quantitative HCG level or pregnancy test 6 weeks after any completion of any pregnancy event. You know, this is one of gynecology's success stories, and you know, it's due to the sensitivity of these tumors to chemotherapy. We have almost the perfect tumor marker to follow these patients, and that's the human chorionic gonadotropin, HCG levels. We've developed specialized treatment centers around the world. There are 2 in the United States, here and at the Brigham and Women's Hospital, Harvard, and Boston, that people can consult with and or send patients for treatment. We've identified prognostic factors that allows individualization of treatment, and we use a variety of treatments: chemotherapy, various types of radiation therapy, and surgery to manage these diseases. We look back at patients who had failed treatment elsewhere and then were sent to our center for subsequent treatment, and the reasons for treatment failure elsewhere. And we found that the most common reason for treatment failure elsewhere was that they used single-agent chemotherapy for patients who should have received multi-agent chemotherapy for high-risk disease. The next most common reason for treatment failure was the inappropriate use of the weekly IM methotrexate regimen, either to treat patients who had metastatic disease, high WHO scores, or for patients who had non-postmolar disease. Some patients got the wrong multi-agent chemotherapy, and then there were some patients who were appropriately referred because they had relapsed from remission or had failed initial single-agent chemotherapy. When we look at the results of therapy here at our center, I went and compared the results of treatment from 1962 to 1978 with our treatment from 1979 to 2006, and you can see that our overall survival has increased from 92% up to 98%, and even in patients who were sent to us after failure of treatment elsewhere, our success here has increased from 59% up to 93%. So almost everybody who we treat now at Northwestern is cured of their gestational trophoblastic neoplasia. And thank you very much for your attention.